that is a triangle. AC with masking in the left ear, that is a rectangle. Now coming to the bone, the masking by the band of noise, Baroness box or anything, sometimes in modern audiometry machine, there is the masking automatically, there is masked according to the matching of the threshold. Now the bone conduction, first is the right side, open mouth to the right, and the left, open mouth to the left. It is with and without masking, and with masking is the third bracket. Open mouth to the right, and it is the third bracket, open mouth to the left. And when it is profoundly deaf, you cannot assess the hearing, you just indicate in such a way. This is the drop. That means the AC normally without masking. AC with masking, BC without masking, BC with masking, and it's the profound deaf. This is the sign for the audiometrician. Generally, if we do not mask, there is a chance of crossover. When you are tested one ear, but it can be crossover to the opposite ear. Now, coming to that degree of hearing loss. There is some few opinion difference, but normally it is mild 20 to 40, moderate 40 to 60, severe 60 to 80, and profound is more than 80. Type of the hearing loss, the conductive hearing loss, sensorineural hearing loss, and mixed hearing loss. Mixed hearing loss means there is a conductive component and there is a sensorineural component. Suppose the curve is like that. The bone conduction, it is and the ear conduction, suppose it is you see there is a ear bone gap, but gradually with the higher frequency it is marked with each other. That means there is a mixed deafness. And this type of lower frequency AB gap is seen in otitis media with effusion or secretory otitis media. Lower frequency of sensorineural hearing loss is seen in which disease? Can you tell me? Lower frequency of sensorineural hearing loss. Any disease? Meniere's disease. Why? Because the pathology in helicotrema, it is the apex of the cochlea, and that area of the basilar membrane is responsible for the lower frequency hearing. Higher frequency hearing is the basilar membrane near to the foot plate of the stapes. There is a loss of higher frequency loss. Now, by the audiometry, we can see whether the hearing loss is the progressive. We repeat the audiometry, or it is a fluctuating. Somewhere it is very severe, sometime it is improved, again it is severe. Fluctuating hearing loss sometimes is associated with that is the Meniere's disease also. And as because there is mostly where there is a endolymphatic change and endolymphatic hydrops. According to the condition of the endolymphatic hydrop, there is a chance of fluctuating hearing loss. Sometimes it is a stationary. Now again we assess the response. We given a treatment and again do the, after few months, after few days, we again do the tympanometry, audiometry. Suppose we do the tympanoplasty for a central perforation. After 3 weeks of the tympanoplasty, we go for the audiometry. Whether it is improved preoperatively, the audiometry, it is improved than that or not. Now, last is the hearing aid selection. Hearing aid selection, it depends upon the best discrimination score or optimum discrimination score, which is generally, we have ascertained the optimum discrimination score by the speech audiometry. That means the discriminating score. And second thing is the dynamic range. What is the dynamic range? The comfortable intensity and the loud discomfort level. The intensity is increased and it is near about 130 decibel. It is very much painful. And the difference between the comfortable level and this loudness discomfort level, this dynamic range is necessary to select or programming the digital hearing aid. Next is the medico-legal partners. Nationally, there is a handicap board and the regulation of the handicap board. Hearing level or the deafness in which level, handicap will be how much. If you are ENT surgeon, if you posted at the level of the district level, you have to attend the board and you have to certify the handicap, you issue the handicap certificate for the deaf people. So, that is a medico-legal importance of the pure tone audiometry. Second medico-legal importance is that is the compensation. If a labor working in a lathe machine zone and the intensity of the sound, I already taught you that when it is in the noise, it is represented by A, not by HL. 90 decibel A, the noise level is there. And exposure is 8 hours per day. And if it is more than 10 years and there is any deficit of the hearing level, the authority or the employer should compensate. That is the rule. That is the medico-legal importance. Already I have told you that conductive hearing loss in the low frequency, that is the otitis media with effusion, and in stapedial fixation, the conductive loss in the higher frequency. That means that is the otosclerosis, the conductive loss in the higher frequencies. Now, the second very interesting and important question, what is the Carhart's notch? And which is the significant features of the Carhart's notch? Can you tell me? Carhart's notch. Do you know? Do you know that? Yeah, then what is that? There is a notch in which frequency? No, it is the 2000. That is, the Carhart's notch is a characteristic of otosclerosis or otospongiosis, any terminology. Now, the Tondorf, the scientist, first give the hypothesis the whole ossicular chain has some resonating frequency, and it is a species specific. It is lowest in case of the cat, but in human being that resonating frequency of the oscillating chain is 2000 Hz. And when there is a loss in that resonating frequency, there is a notch. Similarly, there is a notch in another pathology, but the deafness type is different. That is a sensorineural hearing loss, and there is a notch or a dip in 4000 Hz, that is acoustic blast trauma or acoustic trauma. That may be a very short question. That is a notch in the 4000 Hz in pure tone audiometry. Diagnosis 1, 2, 3, 4. The MCQ question can be given. Now, next thing, the recruitment. You heard this term recruitment. Recruitment, when you will be recruited by any employer, that is the recruitment. The same thing is here. When there is a cochlear pathology, if you increase the intensity gradually for a definite frequency, suddenly the frequency will increase more in case of the defective ear in comparison to the normal ear. That means the damage of the outer hair cell, primarily they are not be alert, they are not stimulated. Suddenly, after certain decibel of frequency, a bunch of outer hair cell is stimulated, and you will listen the sound very harshly and you will be annoyed enough. And that is due to the recruitment. If I put a graph, that is a here is the intensity. This curve is given for the intensity. It is starting from, suppose it is starting from 0 decibel, or it is a 10 decibel, better to say. And it is increase. It is the 40 decibel. It is the 50 decibel. And it is the loudness. You see, this is the loudness sensation, the loudness feeling. In normal ear, it is increasing symmetrically. But in the defective ear, it starts from 40 decibel. There is a 40 decibel loss, and you see, increasing the intensity, it is also, sensation also increase, but it is sharply increase and merge in that area. And that is the recruitment. Much amount of outer hair cell now stimulated. By this theory, loudness balance between the ear, there is a test known as the Fowler's binaural loudness test. Fowler's binaural loudness test, unilateral hearing loss, a tone of 1000 Hz alternately giving to the normal and affected ear to match the loudness. Begin with a 20 decibel above the threshold in case of the normal ear and in case of the affected ear. If it is a 30 decibel loss in the affected ear, you start with 50 decibel. But in the normal ear, we start with the 20 decibel. Increment of the loudness, 10 decibel in each state. And it will increase up to the level where it is matched with the normal curve or the end of the audiometry machine. একটা audiometry machine যতদূর increase করতে পারা যায় 10 decibel increment দিয়ে সেটা করে দিতে পারি। দেখা যাবে মিলছেই না কোথাও, ও সোজা বেরিয়ে চলে যাচ্ছে। এরকম হতে পারে কার্ভ। আবার কার্ভটা গিয়ে 10 decibel increase করতে করতে ওর সাথে গিয়ে মার্জ করে গেল। আবার ওই রকম ভাবেই ও উঠছে। The initial difference maintained in the normal conductive hearing loss and neural or retrocochlear hearing loss. The red curve is common for normal conductive hearing loss and retrocochlear hearing loss. But this blue curve is characteristic of the cochlear pathology. Another test known as the SISI, that is the small increment sensitivity index. SISI, SI, capital SI, that is the small increment sensitivity index. What is done? A continuous tone, 20 decibel above the threshold, sustained for 2 minutes. 1 decibel increment is given each 5 seconds. And then the patient asked to give the response. If the 20 such belief is delivered, and score will be assessed by the percentage. That means a 20 decibel above the threshold always in the defective and the normal ear. Every 5 seconds there is the 1 decibel rise. And এই যে রাইজ করছে, প্রতিটাতে একটা বিপ করছে, বাড়ছে, এইটা কতটা রেসপন্স করছে সেটা পার্সেন্টেজ স্কোরিং দিয়ে অ্যাসেস করা হয়। দেখা যাচ্ছে ইভেন ইন দ্যাট টেস্ট অলসো দ্য ককলিয়ার প্যাথোলজি, যেহেতু রিক্রুটমেন্ট ছিল, শর্ট ইনক্রিমেন্ট দেওয়াতেও তার সেন্সেশনটা বেশি হচ্ছে, যার জন্য দ্য স্কোরিং ইজ মোর দ্যান 70% or more. But in case of the conductive hearing loss, neural hearing loss, it is less than 20%. Lastly, it is the Carhart tone decay. It is a typical for a neural pathology. If you give a continuous beep, after certain time, gradually that will decay. It is a characteristics of any neural pathology. If you give a stimulation, it will decay after some time. It is the nerve fatigability. Retrocochlear lesion like acoustic neuroma or the retrocochlear lesion, we will get it. Normal ear, they can hear a sound for 60 seconds. The tone of 4000 hertz. Here is the 4000 hertz. But in the SISI, it is that only mentioned the how much above. This is the SISI is the definite any frequency, any 1000 hertz or like that. But in the tone decay 4000 hertz, 5 decibel above the threshold for 60 seconds you can given. And after some time, if there is a neural pathology, he or she cannot hear it. gradually it will decay, and the decay is the proof for the retrocochlear or the neural pathology. Intensity is increased sometime, 25 decibel or more. In retrocochlear lesion, that is, decay is there. That is the tone decay curve. We have said the tone decay curve, Carhart's tone decay curve. That means a definite frequency, a definite intensity increase, a tone is given, 4000 Hertz, 5 decibel above the threshold for 60 seconds, and the intensity is increased after the decay, and we will come until it is listened for 60 seconds. You will see number of intensity is more required for the retrocochlear or neural pathology, because there is a decay is more in case of the neural pathology. That means recruitment is more in cochlear pathology, Fowler's test, recruitment test, and SISI, the percentage is more than 70% for cochlear pathology, but in tone decay, the neural pathology, the decay is more. These are all subjective tests. If the patient or the client is not cooperative, the baby is not cooperative, then we cannot do it. But now we are coming to the main objective audiometry. That is the impedance audiometry or tympanometry. What tympanometry ki dekhai? It shows the resistance of the conductive system, that is the tympanic membrane, ossicular chain, and the stapes foot, and the air inside the middle ear cavity. Simultaneously, it shows the compliance of the sound wave. That is the same thing. That means the resistance to the ossicular chain and compliance to the sound wave. মানে একই জিনিস আমরা দুই ভাবে দুজনের ক্ষেত্রে ব্যবহার করছি। ওর ক্ষেত্রে একটা ভাবে বলছি, ওর ক্ষেত্রে আরেকটা ভাবে বলছি। টিম্প্যানোমেট্রিতে কি করা হয়? Suppose external auditory canal. টিম্প্যানোমেট্রি যে প্রোবটা ঢোকানো হয়, সেই প্রোবটায় তিনটে পার্ট। এইটা দিয়ে একটা এয়ার প্রেসার দেওয়া হয়। এয়ার প্রেসারটা দেওয়া হয় respect of the middle ear pressure or atmospheric pressure. It may be more than the atmospheric pressure or it is the less than the atmospheric pressure. And it is measured by the it is either in the curve, it is the atmospheric pressure is either, it is starting from minus 200 millimeter of H2O. It is equal pressure with the atmospheric pressure or the middle ear pressure, that is the 0. It may be here the minus 200 plus 200 of millimeter of H2O. That pressure is created. And here is the sound is given. and here is the microphone. The sound is going to that part and it is partially reflected and it is received by the microphone. And that was calculated and represented by the computer in that machine of impedance audiometry. This is the compliance curve, different type of compliance curve. It may be that is the B type of curve, or it may be a C type of curve. That means the peak in the negative pressure, that is due to the retraction of the tympanic membrane, the negative pressure. The B type of curve generally, if there is some fluid inside the middle ear, there may be, this is C. Now, in A, it is a short A known as AS. Though I do not believe, some says the AS sometimes represent the otosclerosis. Normal A is the normal ear, normal compliance. And another curve is A plus peak is not formed, that is AD. Oh, second. AD. This is due to the subluxation of the ossicular chain or maybe thin drum. AD curve, A curve, AS curve, the C curve, the B curve. That is the impedance audiometry and it is an objective test. It does not require any personal response. So, we can combat the malingerers, we can combat some, we can assess the infants or the children by that. Eustachian tube function. Do you know what is the functions of the Eustachian tube? To maintain the air pressure of the middle ear and the atmosphere. And second function is the clear the secretion of the middle ear to the nasopharynx. These are the two functions. Before going to do the tympanoplasty, we should assess the Eustachian tube function, because if there is a defective Eustachian tube function after doing the tympanoplasty, the result will not be satisfactory. Now, Eustachian tube function in a perforated drum, two functions you can assess. You ask the patient to blow or ballooning of the oral cavity by giving the pressure, the air will come out through the perforation. Another thing, the ciliary function, that is the discharge of the middle ear go to the nasopharynx, that can be done by if you put a drop of saccharin or a honey inside the middle ear cavity and you take your stopwatch, you can assess the time when it will be reached to the nasopharynx. The test will be sweet in the nasopharynx area. And that you can assess the ciliary function also. But normally, we are concerned with the Eustachian tube function when there is a questionable otitis media or effusion. What is done? A pressure is created minus 200 to the plus 200, and we ask the patient to swallow 5 times in 20 seconds, and that will equalize the pressure. I increase the pressure to plus 200 and ask the patient to swallow 5 times in 20 seconds. If it can equalize the pressure to the 0, then Eustachian tube function is normal. Similarly, the negative side. Otherwise, you will go for the treatment of Eustachian tube patency maintenance treatment either by a nasal decongestant, by antihistaminic if there is a running nose, or there is other surgical procedure for the Eustachian tube abnormality repair, or ballooning also there. Oh, another thing is that, do you know Grommet? Grommet tube. The otitis media with effusion, the treatment is tympanostomy in the anterior inferior quadrant, the radial incision. Radial incision. This is the malleus, and you will give a radial incision, and you put a Grommet tube. The circumference is bigger and it will go inside, and this portion will up the tympanic surface of the tympanic membrane, mostly the ventilation of the middle ear cavity. But I have done my thesis work on the otitis media with effusion many years back. I have seen after placing the Grommet tube, still the pathology is going on. Actually, we should done a same thing what we have done in Eustachian tube patency test. If the Grommet is patent, then the pathology will be subside. So, patency of the Grommet should be maintained either by further microscopic examination, and by a needle you push some water or the dexamethasone, that means the decadron, 0.1 millimeter through the Grommet tube to wash the Grommet aperture, and then ultimately it will heal or it will improve. Class নিচ্ছি। Now, the main test is not the impedance. The main test, the difficult part of that is the acoustic reflex. Acoustic reflex. Now, sometime the question has come to draw the neural pathway of the acoustic reflex. This is the pons. This is cochlea. This is the nucleus here. The nerve, the synaptic connection. And it is the olivary area. Here the nerve in that way, and Here is in that way. This is the superior olivary area. The superior olivary area and trapezoid body this is the motor nucleus of cranial nerve 7, the facial nerve. That is the motor nucleus. Cranial nerve 7. Here is the trapezoid body. Superior olivary complex. And here is the stapes and stapedius muscle directly controlled by the facial nerve. So the acoustic reflex is a ipsilateral and contralateral. It is the area of the pons. Sound level is given 70 decibel or 100 decibel more than the threshold, and that will give a curve or a peak in that curve. Why? Because when you take the graph of the compliance, suddenly stapedius muscle will contract and then fix the whole ossicular chain and tympanic membrane, and there is a peak or a curve will arise. That will give the sign for the stapedial reflex. Suppose the curve is going like that. The stapedial reflex may be like that, or sometimes the stapedial reflex may be like that. That means the stapedial reflex, sometimes it is seen if there is contralateral absence of the stapedial reflex, sometimes both are absent in the stapedial reflex. No reflex curve is there. Or how it is interpreted and what disease interpreted by that curve. If there is a infant, this objective test is very much required. To identify the Mallinger stapedial reflex is required. This test is required. When there is a cochlear pathology, we will get the stapedial reflex, but due to the recruitment, it will be more 40 decibel or 50 decibel more than the normal ear. We will get the stapedial reflex. Sometimes the reflex amplitude is low. You see, this is the reflex amplitude, the flat type of reflex can you see in case of the retrocochlear lesion. Now the facial nerve damage. If the damage is above the nerve emerging from the facial nerve, the nerve for the stapedius muscle emerging for the facial nerve above that level, then we will not get the stapedial reflex. If during operation, if I cut or damage the facial nerve above the emerging site of the bar, it is proximal to the emerging site of the nerve to the stapedius, then we will not get any stapedial reflex. If the nerve is not repaired or the nerve damage is not repaired, the facial paralysis needs some intervention. It can be ascertained by the stapedial reflex. If the stapedial reflex, the patient has gained the stapedial reflex again, that means there is a progressive repair automatically going on and the facial nerve damage is repaired. But if it is not, the reflex is absent for a long day, that means there is no chance of facial nerve repair automatically, or it will not improve. Then you go for the grafting, facial nerve grafting. That means to assess the facial nerve paralysis, acoustic reflex test is very much helpful. Abnormal, it is the absence of acoustic reflex with normal tympanogram. Tympanogram is normal, means the ossicular chain pattern is normal, but the stapedial reflex is absent. That is the profound hearing loss. Because the retrocochlear portion, the message is not coming. The pathology in the nerve. But there is a tympanogram is abnormal. That means there is a conductive hearing loss or it is a mixed type of hearing loss. So we will always read it with tympanogram, the acoustic reflex. If there is acoustic reflex decay, then it is a retrocochlear lesion. As already I have told, the neural pathology, there is a common phenomena of decay by which we explain the tone decay test of Carhart. Now, BERA. It is the integrity of the pathway of the neural pathways. It is brainstem evoked response audiometry. Generally, the 5 waves we have seen, but there is if we can delineate properly, there is a 7 waves for the BERA, and the BERA is measured by 1000, 4000 Hertz. The 7 waves generate within 10 milliseconds. What we will measure? The latency of the peak. That is the 1, a 2 curve, the 3, and then the 4 and 5 is like that. The 5 one is the most important. This is 1. And what is the absolute latency or the latency in between that 2 peak? This type of measurement is done. What is the uses of the BERA? The threshold of hearing for the children, uncooperative patient, and site of lesion. But it's not so important. We are generally, by BERA, we have ascertained whether there is a severe or profound loss or hearing loss is there or not. Now, what is the definite site? The number 1 wave is for the 8th cranial nerve. Number 2 is for the cochlea. Number 3 is the superior olivary complex. Number 4 is the lemniscus. And 5 for the inferior colliculus. Again, I repeat. Number 1 for the 8th cranial nerve. Number 2 for the cochlear nerve. And 3rd for the superior olivary complex. 4th for the lateral lemniscus. And 5 for the inferior colliculus. Now, interpeak latency 1 to 3. It's 2 milliseconds. 1 to 3. Interpeak latency is 2 milliseconds. 3 to 5, 2 milliseconds, and 1 to 5 is the 5 millisecond. This latency is different for different ear when there is a acoustic neuroma or sonoma of the 8th cranial nerve of 1 ear. There is a difference of the latency of the 5th peak or there is a latency difference in between the two waves also, but a two peak. It is the retrocochlear lesion. Otoacoustic emission, that is mostly the sound produced. It is the low intensity sound produced by the outer hair cell of the cochlea, produced spontaneously and responds to the acoustic stimuli. Otoacoustic emission whether the baby is sleeping or not, it is not necessary. If the baby is quiet, we can assess the otoacoustic emission. And it is a screening method generally. There is a different type of otoacoustic emission, the spontaneous otoacoustic emission, that is the evoked otoacoustic emission. We are giving some evoke by the sound stimuli, and that is the transient sound stimuli, that is the TOA. Sometimes there is the distortion product OAE, another type of OAE, and this everything is required for assessing the hearing loss in a very early age group. That is the 1 month. We have to assess whether there is the cochlear damage or not. We should do the OAE. There is a screening one. Another thing is very important, but not for the MBBS student, that is the ASSR, the auditory steady state response. It is another type of objective audiometry, and here is what is the advantage? The frequency spectrum is more than BERA. That means it is more sensitive than BERA. And it is very easier to analyze and is frequency specific. ASSR, a test mostly used for the assessment of the cochlear implant patient. Now you should know that limits. OAE, TOE, transient evoke response, otoacoustic emission, that will be absent. You will not get it if the loss is more than 30 decibel. DPOA you cannot get if the hearing loss is more than 50 decibel. ABR cannot test when the hearing loss is more than 80 decibel. ASSR is the only method by which you can measure hearing loss up to 120 decibel. These are mostly used when there is a non-cooperative patient. In case of the infants, mentally challenged patient, then you can use. Now, the infants, generally the newborn, we are doing the automatic OAE. Second part, we go for the brainstem evoke response audiometry. And in the third stage, we go for the assessment of all the structural or the clinical assessment, and finally we go for the brainstem evoke response audiometry, and we consider the baby for urgent intervention, maybe by hearing aid, maybe by cochlear implant. And next, another thing is important, that is the speech audiometry. I will not cover it now. The speech audiometry, two things I will utter, that is the speech reception threshold. It is the minimum intensity. 50% of the spondy words repeat correctly. What is the speech reception threshold? It is the minimum intensity, 50% of the spondy word repeat correctly. What is the spondy word? It is a 2-syllable word, equally stressed, like oatmeal, popcorn, dada mama, baba kaka, this type. This is the speech reception. And speech discrimination is another thing which is early we are losing during the presbyacusis, and it is the percentage of phonetically balanced word lost correctly heard in the definite intensity. A definitely curve is there. There is the optimum discrimination score. Another question was given, that is the probably in your NEET examination, NEET-UG, NEET-PG. That is the rollover curve. The rollover curve is nothing but a graphical representation of the speech audiometry. That is the phonetically balanced, the percentage of the phonetically balanced word correctly uttered in a definite decibel. In case of sensorineural deafness, their curve will rise and then it will fall. That is the rollover curve, and which is characteristic for the neural deafness. That is almost I have completed the audiometry. Though audiometry and audiology is a very, very tough chapter, and every point is critically you should read. But for your MBBS examination, to significantly pure tone audiometry, you should read the pure tone audiometry very sincerely, and speech reception threshold, speech discrimination, impedance audiometry, acoustic reflex, otoacoustic emission, and BERA. These are sufficient. That means the pure tone audiometry, speech reception threshold, speech discrimination score, impedance audiometry, otoacoustic emission, and BERA. That will be sufficient. You should read this portion very sincerely. Otherwise, you can miss the very short MCQ type of question.